47 Barrett Esophagus. 47 Stewart John Speckler, Rhonda F. Souza. Chapter Outline Diagnosis. 691 Epidemiology. 691 Pathogenesis. 692 Molecular Biology of Neoplasia. 693 Dysplasia. 694 Management. 695 Treatment of GERD. 695 Aspirin and other NSAIDs. 696 Endoscopic surveillance for dysplasia. 696 Treatment of mucosal neoplasia. 696 Recommendations. 699 Barrett esophagus is the condition in which an abnormal columnar epithelium that has both gastric and intestinal features and that is predisposed to malignancy replaces the stratified squamous epithelium that normally lines the distal esophagus. 1 The condition is named for Norman Barrett, an Australian surgeon who drew attention to the columnar-lined esophagus in 1950. 2 Barrett esophagus is a consequence of chronic GERD, which damages the esophageal squamous epithelium and causes it to heal through a metaplastic process in which columnar cells replace reflux-damaged squamous cells. The columnar-lined esophagus causes no symptoms, and the condition has clinical importance only because it is a risk factor for esophageal adenocarcinoma, a tumor whose frequency has increased more than 7-fold over the past several decades. 3 Diagnosis. Barrett esophagus is diagnosed by endoscopic examination, and 2 criteria must be fulfilled. First, the endoscopist must ascertain that columnar epithelium lines 1 cm or greater of the distal esophagus. Second, biopsy specimens of that columnar epithelium must show evidence of metaplasia, which is a change from one adult tissue type to another. To ascertain that columnar epithelium lines the distal esophagus, the endoscopist first must locate the esophagogastric junction, EGJ, which is recognized as the most proximal extent of the gastric folds, and then determine that columnar epithelium extends 1 cm or greater above the EGJ into the esophagus, Fig. 47.1. Endoscopically, columnar epithelium has a reddish color and velvet-like texture that can be distinguished readily from normal esophageal squamous epithelium, which is pale and glossy. There is disagreement among experts regarding the histologic type of epithelium required to confirm that there is metaplasia in the esophagus. 1 Virtually all would agree that the finding of an intestinal type epithelium with goblet cells, which has been called intestinal metaplasia, specialized intestinal metaplasia, or specialized columnar epithelium, is clear evidence of metaplasia. Most published studies on Barrett esophagus have used intestinal metaplasia as a requisite diagnostic criterion. However, some authorities argue that cardiac-type mucosa, which is composed almost exclusively of mucus-secreting cells, also is metaplastic or has malignant predisposition, and can be considered diagnostic of Barrett esophagus. 5 Although this debate remains unresolved, U.S. gastroenterology societies require the demonstration of intestinal metaplasia with goblet cells as a diagnostic criterion for Barrett esophagus. Barrett esophagus can be further categorized as long segment, when the metaplastic epithelium extends at least 3 cm above the EGJ, or short segment, when cm of metaplastic epithelium lines the distal esophagus. 6 Short segment Barrett esophagus, which is by far the most common form of the disease, was not widely recognized until it was described by Speckler et al. In 1994. 7 Another proposed system for categorizing Barrett esophagus, the PROG-C and M criteria, identifies the circumferential, C, and the maximum, M, extent of Barrett metaplasia. 8 Data suggest that the cancer risk in Barrett esophagus varies with the extent of the metaplastic lining. Epidemiology Barrett esophagus typically is discovered during endoscopic examinations performed for the evaluation of GERD symptoms in middle-aged and older adults. 9 The average age at the time of diagnosis is approximately 55 years. The condition is rare in children younger than age 10 and virtually non-existent in children younger than age 5. 10 White men predominate in most series, and, for unknown reasons, Barrett esophagus is uncommon in Black and Asian populations. 11 Although the prevalence has increased recently in Asian countries. 12 Cigarette smoking is also associated with Barrett esophagus. 13 Among adult patients who have endoscopic examinations because of GERD symptoms, long segment Barrett esophagus is found in 3% to 5%, whereas 10% to 20% have short segment Barrett esophagus. In the general adult population of Western countries, the prevalence of Barrett esophagus, predominantly short segment, is between 1.6% and 6.8%. 14,15 Published estimates on the annual incidence of cancer in patients with long segment Barrett esophagus have been as high as 2.9%, but a report published in 2000 showed that many of those estimates were exaggerated because they were based on older, small studies that suffered from publication bias. 16 For the first decade of the new millennium, it was widely assumed that the cancer risk for patients with non-dysplastic Barrett esophagus was approximately 0.5% per year. However, more recent studies suggested that the cancer risk for such patients is even lower, in the range of only 0.12% to 0.33% per year. 17-20 The epidemiology of esophageal adenocarcinoma is similar to that of Barrett esophagus. 21-24 GERD is strongly associated with both conditions, and, like Barrett esophagus, esophageal adenocarcinoma affects white men predominantly. Obesity, especially with central adiposity, predisposes to both Barrett esophagus and esophageal adenocarcinoma. 25 And the dramatic rise in the frequency of obesity in the USA has paralleled a similar rise in the prevalence of Barrett cancer. The mechanisms underlying these associations with obesity are not clear but may relate. 692 Part V Esophagus 691 Fig 47.1 Endoscopic photograph of Barrett esophagus. The arrows mark the EGJ, which is identified endoscopically as the most proximal extent of the gastric folds. The reddish color and velvet-like texture of the Barrett epithelium contrast sharply with the pale and glossy appearance of the esophageal squamous epithelium. Note that the Barrett columnar epithelium extends well above the EGJ to line the distal esophagus. To the fact that central adiposity predisposes to GERD, perhaps by increasing intra-abdominal pressure, see also chapters 46 and 48. Obesity also is associated with elevated serum levels of proproliferative hormones such as insulin-like growth factor I and leptin, and with decreased levels of the antiproliferative hormone adiponectin, factors that may contribute to carcinogenesis in Barrett esophagus. It has been proposed that the declining frequency of infection with HP in Western populations also may be contributing to the rising frequency of esophageal adenocarcinoma. See Chapter 48. A number of studies have suggested that HP infection may protect against the development and neoplastic progression of Barrett esophagus, perhaps because, in a subset of patients, this infection may prevent GERD by decreasing gastric acid secretion. 21 Other factors that appear to protect against the development of esophageal adenocarcinoma include the use of aspirin and other NSAIDs and the consumption of a diet high in fruits and vegetables. 22-24 Although cigarette smoking and alcohol consumption are very strong risk factors for squamous cell carcinoma of the esophagus, cigarette smoking only modestly increases the risk for esophageal adenocarcinoma and alcohol does not appear to affect that risk at all. Finally, it has been proposed that the rising incidence of esophageal adenocarcinoma might be due to increased intake of dietary nitrate in green leafy vegetables that has resulted from the widespread use of nitrate-based fertilizers in Western countries following World War II. 26 Pathogenesis Barrett pathogenesis begins with esophageal injury by GERD, and patients with long segment Barrett esophagus often have severe GERD. See Chapter 46. Table 47.1 lists some physiologic abnormalities that have been reported in Barrett patients and suggests how those abnormalities might contribute to GERD severity. Individual patients may exhibit any, all, or none of those abnormalities, and their prevalence in Barrett esophagus is disputed. For example, some investigators have described normal gastric acid secretion in patients with long segment Barrett esophagus. 27 In addition, Many patients with short-segment Barrett esophagus have no GERD symptoms. Table 47.1 Proposed physiologic abnormalities contributing to GERD in patients with Barrett esophagus * abnormality potential consequences extreme hypotension of the gastroesophageal reflux lower esophageal sphincter ineffective esophageal motility defective clearance of refluxed material gastric acid hypersecretion reflux of highly acidic gastric juice duodenoggastric reflux esophageal injury caused by reflux of bile acids and pancreatic enzymes decreased salivary secretion delayed healing of reflux damaged of EGF esophageal mucosa decreased esophageal pain failure to initiate therapy sensitivity to refluxed caustic material * see chapter 46 for detailed discussion of these abnormalities. EGF, epidermal growth factor, and no endoscopic signs of esophagitis. Indeed, one large study has suggested that short-segment Barrett esophagus may affect approximately 5% of adults, irrespective of the presence of GERD symptoms. 14 Studies have shown that, even in healthy volunteers, the very distal esophagus can be exposed to acid for more than 10% of the day. 28 Such acid exposure can damage the esophagus directly and indirectly when nitrite, generated from dietary nitrate, reacts with acid to produce nitric oxide. High concentrations of nitric oxide in the distal esophagus have been observed in patients with GERD who have ingested nitrate. 26 In Barrett esophagus, reflux-damaged squamous epithelium is replaced by an intestinal-type epithelium that, presumably, is more resistant to GERD injury. Because intestinal-type cells are not found normally in the esophagus, this process must involve GERD-induced molecular reprogramming of key developmental transcription factors in the progenitor cells giving rise to the metaplasia. 29 However, the identity of these progenitor cells is not clear, and there are several candidates. It has been suggested that Barrett metaplasia develops when GERD causes mature esophageal squamous cells to transdifferentiate into columnar cells or when GERD causes abnormal differentiation of immature progenitor cells. 30 Potential esophageal sources for these progenitor cells include basal cells of the squamous epithelium, or cells lining the ducts of esophageal submucosal glands. 30-31 Alternatively, as discussed in chapter 46, Barrett progenitor cells might migrate into the reflux damaged esophagus from the gastric cardia. 32 From a nest of residual embryonic type cells that can be found at the gastroesophageal junction. 33 Or from a recently described population of transitional basal cells located at the squamocolumnar junction. 34 Finally, in a rat model of reflux esophagitis, Barrett metaplasia was shown to develop from circulating bone marrow stem cells. 35 Genes upregulated by reflux esophagitis that have been proposed to contribute to the squamostocolumnar metaplasia of Barrett esophagus include CDX genes, which are known to mediate the differentiation of intestinal epithelial cells, and the hedgehog target genes BMP4, bone morphogenetic protein 4, and FOXA2, which also are involved in columnar cell differentiation. 36-38 Barrett epithelial cells appear to be more capable of resisting reflux-induced esophageal injury than the native squamous epithelial cells. Unlike squamous cells, for example, Barrett cells secrete mucins and express the tight junction protein claudin 18, features that render the epithelium more resistant to acid peptic attack. 39-40 Unfortunately, Barrett epithelium also is predisposed to neoplasia. Chapter 47 Barrett esophagus 693 47 Molecular biology of neoplasia during carcinogenesis. Barrett epithelial cells accumulate genetic and epigenetic alterations that endow the cells with the core physiologic attributes of malignancy proposed by Hanahan and Weinberg in 2000. See Chapter 1.41. Those attributes include self-sufficiency in growth signals, insensitivity to anti-growth signals, evasion of apoptosis, limitless replicative potential, sustained angiogenesis, and the abilities to invade adjacent structures and to metastasize. Fig 47.2. More recently, Hanahan and Weinberg added two additional physiologic hallmarks of malignancy: the ability to reprogram energy metabolism to support continuous proliferation, and the ability to evade destruction by immune cells, T and B lymphocytes, macrophages, and natural killer cells. 42 Numerous genetic alterations have been described during the neoplastic progression of Barrett esophagus. Although a single such alteration may have multiple disparate effects, conceptually it can be useful to classify the alteration according to the major physiologic cancer attributes that it endows. 43 For example, the expression of oncogenes, e.g., cyclin D1, KRAS, growth factors such as transforming growth factor alpha and growth factor receptors such as EGF receptor enable Barrett cells to acquire self-sufficiency in growth signals. Insensitivity to anti-growth signals occurs primarily through the inactivation of tumor suppressor genes, e.g., TP53, P16. Inactivation of TP53 also enables cells to evade apoptosis. Reactivation of the enzyme telomerase, which enables the cells to replace telomeres needed for cell division, can endow the cells with limitless replicative potential. Neoplasms can increase their vascular supply by secreting angiogenic factors such as vascular endothelial growth factor. Finally, for neoplastic cells to invade and metastasize, they must dissociate themselves from surrounding cells by disrupting cell adhesion proteins such as the cadherins and catenins, and by degrading the extracellular matrix through the secretion of enzymes such as matrix metalloproteases. In Barrett esophagus, the acquisition of these core physiologic attributes of malignancy is facilitated by genomic instability in a tumor-promoting microenvironment. 44 Barrett epithelial cells display genomic instability by gains or losses in segments of chromosomes that alter the cell's DNA content. Aneuploidy is the condition in which there is abnormal cellular DNA content, and aneuploid cells are at increased risk for neoplastic progression. 45 Aneuploidy can be detected by flow cytometry, by fluorescence in situ hybridization, and by automated image cytometry. The latter two techniques are more feasible for routine clinical practice. 46,47 In some neoplasms, infiltration by immune cells with tumor-promoting effects also contributes to the acquisition of malignant attributes, but little is known about the tumor-promoting effects of immune cells in Barrett esophagus. 45,48 Aneuploidy has been proposed as a biomarker for neoplastic progression in Barrett esophagus, as have a number of the genetic alterations discussed in the preceding paragraph. Although there have been some promising studies, especially those using panels of biomarkers, 49 gastroenterology societies presently do not endorse the routine clinical use of biomarkers for clinical management of patients with Barrett esophagus. Recent advances in genomic techniques such as whole genome sequencing and whole exome sequencing, which is limited to gene coding regions, have contributed greatly to knowledge of how Barrett cells become tumor cells. Whole exome sequencing of DNA extracted from areas of Barrett metaplasia associated with Barrett adenocarcinomas has revealed a frequency of somatic mutation in the non-neoplastic metaplasia higher than that found in prostate or breast carcinomas, and with a mutational pattern indicating genomic damage caused by oxidative stress, likely due to GERD. See Fig 47.2. 50 Both the non-dysplastic Barrett metaplasia and associated adenocarcinomas exhibit mutations in the P53 tumor suppressor gene, evidence that P53 mutations occur early in Barrett carcinogenesis. Oncogene activations appear to occur later, because they are found only in dysplastic and cancerous tissues. 50 Interestingly, the new genomic techniques have revealed two general pathways for Barrett carcinogenesis: the traditional pathway, which involves the stepwise accumulation of alterations in tumor suppressor genes, followed by oncogene activation, genomic instability, and malignant transformation, and the genome doubled pathway, in which P53 mutation is followed by whole genome doubling, leading to genomic instability, oncogene amplification, and malignant. Fig 47.2 Molecular biology of neoplasia in Barrett esophagus. The core physiologic attributes of cancer cells are shown in blue. The two additional pathophysiologic features proposed in 2011 are shown in green. The boxes in orange are the facilitating features such as genomic instability and a tumor-promoting microenvironment that may allow Barrett cells to quickly acquire the physiologic attributes of cancer cells. Energy metabolism reprogramming, evade destruction by immune cells, limitless replicative potential, self-sufficiency in growth signals, i.e., oncogene activation, insensitivity to anti-growth signals, i.e., tumor suppressor gene inactivation, evasion of apoptosis facilitating features Barrett cancer cells Barrett cell genomic instability, i.e., aneuploidy or whole genome doubling, sustained angiogenesis tissue invasion and metastasis tumor promoting microenvironment, i.e., oxidative stress, 694 Part V esophagus transformation, Fig 47.3. Most tumors in Barrett metaplasia, 62.5%, appear to develop through the genome doubled pathway, which can be a far more rapid pathway to malignancy than the traditional pathway. 50 Rapid cancer development through genome doubling might explain the frequent failure of endoscopic surveillance to detect cancer progression in Barrett esophagus. Unlike the aforementioned studies in which somatic mutations are identified by genomic analyses of tissue specimens, genome-wide association studies, GWAS, identify germline alterations and typically are performed using DNA in whole blood specimens. GWAS have shown that unrelated subjects with Barrett esophagus and esophageal adenocarcinoma have substantial overlap of single nucleotide polymorphisms, SNPs, at specific locations in the genome, suggesting a shared genetic susceptibility for Barrett esophagus and its cancer. 51 More recent GWAS analyzing selected SNPs within inflammatory pathways have found a significant association between germline variations in the cyclooxygenase pathway, specifically in the antioxidant microsomal glutathione S-transferase 1 gene, and the development of Barrett esophagus and esophageal adenocarcinoma. 52 Another GWAS explored the association between 7 SNPs implicated as risk factors for Barrett esophagus with several well-known epidemiologic risk factors for Barrett esophagus, GERD, cigarette smoking, and BMI. 53 Only an SNP in the FOXP1 gene, which regulates esophageal development, and the presence of at least weekly reflux symptoms were found to modify the risk of developing Barrett esophagus and esophageal adenocarcinoma. The identification of novel gene-environment interactions by these new omics approaches may well revolutionize our understanding of how Barrett esophagus develops and progresses to esophageal adenocarcinoma. Dysplasia before neoplastic Barrett cells become malignant. Some of the same genetic and epigenetic alterations that endow the physiologic attributes of malignancy also cause morphologic changes in the tissue that pathologists recognize as dysplasia. Fig. 47.4. Dysplasia, also called intraepithelial neoplasia, can be viewed as the histologic expression of genetic and epigenetic alterations that favor unregulated cell growth. 54,55 Dysplasia is recognized by cytologic and architectural abnormalities in esophageal biopsy specimens that include 1. Nuclear changes such as enlargement, pleomorphism, hyperchromatism, stratification, and atypical mitoses, 2. Loss of cytoplasmic maturation, and 3. Crowding of tubules and villiform surfaces. Dysplasia is categorized as low-grade or high-grade depending on the degree of histologic abnormalities, with more pronounced abnormalities assumed to reflect more severe genetic damage and greater potential for carcinogenesis. Pathologists have difficulty distinguishing low-grade dysplasia in Barrett esophagus from reactive changes caused by reflux esophagitis. An inter-observer agreement for the diagnosis of low-grade dysplasia may be less than 50%. Inter-observer agreement is better, approximately 85%. For high-grade dysplasia, but there is substantial disagreement among pathologists in distinguishing high-grade dysplasia from intramucosal carcinoma. See Chapter 48. Oncogene activation and genomic instability. Dysplasia in Barrett esophagus often is associated with visible mucosal irregularities, but those irregularities frequently are subtle and easily missed, especially by non-experts. 56 Furthermore, dysplasia can be patchy in its extent and severity. These factors contribute to the substantial problem of biopsy sampling error in identifying dysplasia. To find dysplasia in Barrett esophagus, endoscopists traditionally have used the Seattle biopsy protocol, a random biopsy sampling system in which 4-quadrant biopsies are taken at 1 to 2 cm intervals throughout the length of Barrett metaplasia. 57 However, a recent analysis of 2 radiofrequency ablation (RFA) trials found that dysplasia is most likely to be present in the proximal half of the Barrett metaplasia segment, suggesting that future biopsy protocols might be modified to Biopsy that proximal segment preferentially 0.58. It is clear that the Seattle biopsy protocol often oncogene amplification Fig 47.3 pathways for cancer development in Barrett esophagus. Metaplastic Barrett cells first acquire mutations leading to inactivation of p53. In the traditional pathway, stepwise accumulation of alterations in the tumor suppressor gene p16, followed by oncogene activation, and genomic instability eventually lead to cancer formation. In Nome doubled pathway, p53 mutant Barrett cells undergo whole genome doubling, followed by genomic instability and ENE amplification, leading to cancer formation. The genome doubled pathway has been proposed as a more rapid pathway to R formation, possibly explaining the failure of endoscopic surveillance to detect cancer progression in Barrett esophagus. Chapter 47 Barrett esophagus 695 47 misses areas of dysplasia and even cancer. A recent systematic review and meta-analysis found that, among patients diagnosed with non-dysplastic or low-grade dysplastic Barrett esophagus on an index endoscopy and who were followed for 3 years or more, 25% of those later diagnosed with esophageal adenocarcinoma had the cancer discovered within 1 year of the index endoscopy. 59. This suggests that the cancers were present and missed at the time of the index procedure. In older series of patients who had esophagectomy performed because endoscopic biopsies revealed high-grade dysplasia in Barrett esophagus, invasive cancer was found in as many as 30% to 40% of the resected esophagi. 60. However, a critical review of those older studies suggested that 13% was a more accurate estimate of the frequency of invasive cancer in this situation. 61. With modern high-definition endoscopes and newer diagnostic techniques such as endoscopic mucosal resection, EMR, c. Later, the rate of missing invasive cancer in patients found to have dysplasia should be very low. A number of advanced imaging techniques have been used to facilitate the detection of dysplasia and early cancer in Barrett esophagus, including chromoendoscopy, autofluorescence endoscopy, magnification endoscopy, narrowband imaging, optical coherence tomography, Raman detection methods, confocal laser endomicroscopy, and volumetric laser endomicroscopy. See Chapter 48. 54,62-64. In the hands of endoscopists with proper training and expertise, these advanced techniques can identify neoplastic lesions that might not be apparent with routine, white light endoscopy. However, gastroenterology societies do not mandate use of these advanced imaging techniques in routine clinical practice, and careful endoscopic examination with high-definition white light endoscopy and random 4-quadrant biopsy remains the standard of care. The overall incidence of cancer development in patients with non-dysplastic Barrett esophagus is approximately 0.25% per year. One study suggests that patients who have non-neoplastic Barrett esophagus develop low-grade dysplasia at the rate of 4.3% per year and high-grade dysplasia at the rate of 0.9% per year. 65. The natural history of low-grade dysplasia in Barrett esophagus remains disputed due to difficulties confirming the diagnosis and contradictory study results. In one study, 2 expert pathologists reviewed pathology slides in 147 patients in whom low-grade dysplasia had been diagnosed at community hospitals in the Netherlands. The experts confirmed the diagnosis in only 15% of cases. 66. In those confirmed cases, however, the cumulative risk of neoplastic progression was 85% after 9 years. In contrast, an American study of 210 patients with low-grade dysplasia followed for a mean of 6.2 years found that the rate of progression of only 0.4% per year and diagnostic consensus among the pathologists was not associated with neoplastic progression. 67. For patients with high-grade dysplasia, cancers develop at the rate of approximately 6% per year. 54. Management treatment of GERD. The general approach to the treatment of GERD for patients with Barrett esophagus is very similar to that recommended for patients who have GERD without Barrett esophagus. See Chapter 46. One important difference, however, is that many authorities advocate PPI maintenance therapy for patients with Barrett esophagus, irrespective of symptoms and endoscopic signs of GERD. This practice is based on indirect evidence suggesting that acid reflux promotes carcinogenesis in Barrett metaplasia and that aggressive control of acid reflux might interfere with carcinogenesis. 68-72 However, this issue remains highly controversial because studies on it have yielded contradictory findings. A meta-analysis of 7 studies, including 2,813 patients with Barrett metaplasia and 317 with Barrett neoplasia, found that PPI use was associated with a significantly decreased risk of high-grade dysplasia and/or esophageal adenocarcinoma, adjusted odds ratio 0.29, 95% confidence interval CI 0.12 to 0.79, 0.73 However, a subsequent meta-analysis of 9 observational studies with 5,712 Barrett patients found that the decreased risk of esophageal neoplasia associated with PPI use was not statistically significant, unadjusted odds ratio 0.43, 95% CI 0.17 to 1.08, 74, and a population-based cohort study of 796,492 Swedish adults on PPI maintenance therapy has even described Fig 47.4 histopathology of dysplasia in Barrett esophagus. This biopsy specimen taken during endoscopic surveillance shows low-grade dysplasia at 11 o'clock and high-grade dysplasia in the center of the photomicrograph. An elevated overall SIR for esophageal adenocarcinoma of 3.93 for PPI users, 95% CI 3.63 to 4.24, 0.75 Nevertheless, most studies suggest that PPIs can reduce the risk of malignant progression in Barrett esophagus. 76 And the latest guideline on the management of Barrett esophagus by the ACC recommends that Barrett patients should receive once-daily PPI therapy for chemoprevention. 77 Studies using esophageal pH monitoring have shown that Barrett patients may be rendered asymptomatic by PPIs given in dosages that fail to normalize esophageal acid exposure. In one such study of 48 patients with Barrett esophagus, 24 had persistently abnormal acid reflux during PPI therapy that had abolished their GERD symptoms. 78 It has been proposed that patients with long-segment Barrett esophagus might be unusually resistant to PPIs, but one study has suggested that this problem is not due to gastric resistance to the anti-secretory effects of PPIs. 79 In that study, patients with long-segment Barrett esophagus treated with high doses of esomeprazole exhibited normal degrees of gastric acid suppression, but up to 23% still had abnormal esophageal acid exposure. This suggests that the so-called PPI resistance of patients with Barrett esophagus is a consequence of their profound reflux diathesis. It has been proposed that fundoplication might be more effective than medical therapy with PPIs for preventing cancer in Barrett esophagus, but high-quality studies on this issue generally have refuted that contention. 80-83 In a recent systematic review and meta-analysis of 10 studies comparing cancer risk for patients who had surgical or medical treatment for GERD, the overall fixed effects model showed that the two treatments were similar in their effects on cancer risk, 0.76, 95%, CI 0.42 to 1.39, 0.84 However, a sub-analysis limited to the 4 most modern studies, published after 2000, suggested that surgery was significantly better than medical treatment for decreasing the risk of cancer in Barrett esophagus, 0.26, 95% CI 0.09 to 0.79. The results of these analyses are inconclusive, and, if fundoplication has any cancer preventive benefit over medical therapy, that potential advantage to an individual patient. 696 Part V Esophagus is small and does not clearly justify the risks of anti-reflux surgery. We do not feel that anti-reflux surgery should be performed solely for cancer prevention in patients with Barrett esophagus. Aspirin and other NSAIDs. Much indirect evidence suggests that aspirin and other NSAIDs protect against esophageal adenocarcinoma, both by inhibiting COX-2 and through mechanisms that are independent of COX-2 inhibition. 85-87 In vitro, NSAIDs have been shown to decrease cellular proliferation, increase apoptosis, and decrease angiogenesis. 88-91 In animal models of GERD and Barrett esophagus, NSAIDs have been shown to decrease both the development of Barrett metaplasia and its Progression to cancer. 92-94 In patients with Barrett esophagus, NSAIDs have been shown to decrease proliferation in Barrett metaplasia. 91 And aspirin in a dose of 325 mg daily, in combination with esomeprazole, reduces levels of prostaglandin E2 in Barrett mucosa. 95 NSAID use also appears to reduce the accumulation of somatic exomic mutations in Barrett metaplasia. 96 A number of epidemiologic and observational studies also have shown that NSAID use is associated with a decreased risk of esophageal adenocarcinoma. 97-99 Although some contradictory data have been reported. 100 Medical societies currently do not recommend the routine prescription of aspirin or other NSAIDs for chemoprevention in patients with Barrett esophagus, because it is not clear that the potential benefits of NSAIDs outweigh their risks of serious GI and cardiovascular side effects. However, patients with Barrett esophagus often have cardiovascular disease and/or cardiovascular risk factors for which aspirin therapy is indicated. 101 Endoscopic surveillance for dysplasia. Although it is common clinical practice to recommend regular endoscopic surveillance to prevent deaths from esophageal adenocarcinoma for patients with Barrett esophagus, authorities have questioned the wisdom of such surveillance with arguments that can be summarized as follows. 102. 1. Endoscopy is expensive. 2. Endoscopy has risks and adverse emotional and financial consequences. 3. The absolute risk of cancer for patients with Barrett esophagus is small, and therefore the large majority of patients derive no benefit from endoscopic surveillance. And 4. There is no proof, in the form of a randomized controlled trial, that endoscopic surveillance for Barrett esophagus prevents esophageal cancer deaths or prolongs patient survival. Proponents of endoscopic surveillance counter these arguments as follows. 1. The concept that surveillance for Barrett esophagus can prevent deaths from esophageal adenocarcinoma is reasonable. 2. No proof of efficacy in the form of a randomized controlled trial is likely to become available in the foreseeable future. 3. A number of observational studies suggest that surveillance is beneficial. 4. Virtually all published computer models on this issue suggest that surveillance can be beneficial. 5. The risks of endoscopy for otherwise healthy individuals with Barrett esophagus are very small. And 6. No study has shown an overall survival disadvantage for patients in surveillance programs. The potentially adverse emotional and financial consequences of establishing a diagnosis of Barrett esophagus are regrettable, but less so than the failure to prevent an esophageal cancer. Therefore, the proponents argue it is ethically wrong for physicians to forego the potentially life-saving practice of performing endoscopic surveillance for Barrett esophagus while awaiting the results of a definitive study that may never appear. Presently, gastroenterology societies favor the arguments of the proponents and generally recommend surveillance, with some qualifications. 103 Because screening large populations of individuals for Barrett esophagus is performed primarily to enroll them in unproven surveillance programs, it is not surprising that such screening is especially controversial. See Chapter 48. The latest guidelines of the American Gastroenterological Association. 101 The ASGE. 104 The Act 77 The American College of Physicians. 105 The British Society of Gastroenterology. 106 and the European Society of Gastrointestinal Endoscopy. 107 Recommend consideration of endoscopic screening for Barrett esophagus only for patients who have multiple risk factors for esophageal adenocarcinoma, including chronic GERD, age 50 years or older, male gender, white race, hiatal hernia, intra-abdominal body fat distribution, central obesity, smoking history, and history of Barrett esophagus or adenocarcinoma in a first-degree relative. Because the risk of esophageal adenocarcinoma is so low for women, the Act specifically states that screening for Barrett esophagus in women is not recommended but could be considered in individual cases of women with multiple risk factors. 77 Treatment of mucosal neoplasia. Mucosal neoplasms such as high-grade dysplasia and intramucosal carcinoma in Barrett esophagus traditionally were treated with esophagectomy. Presently, most patients with mucosal neoplasia are treated with endoscopic eradication therapy, EET, although esophagectomy remains a valid option in highly selected cases. The management of low-grade dysplasia is controversial because of uncertainties regarding the diagnosis and the natural history of the disorder. Nevertheless, most recent guidelines consider EET the treatment of choice for low-grade dysplasia. 77,107,108 Endoscopic therapies. There are two general types of endoscopic therapies available for the treatment of Barrett esophagus. 1. Endoscopic ablative therapy, which uses heat, delivered by laser, electrocoagulation, argon plasma coagulation video 47.1, or radiofrequency energy, cold, cryotherapy, delivered by spraying cold carbon dioxide or nitrous oxide gas, or photochemical energy, photodynamic therapy PDT, to destroy the Barrett epithelium, and 2. Endoscopic resection including EMR, video 47.2, and endoscopic submucosal dissection, in which a diathermic snare or endoscopic knife is used to remove a large segment of Barrett mucosa with submucosa. After these endoscopic treatments, patients are treated with PPIs so that the ablated or resected mucosa can heal with the regrowth of normal esophageal squamous epithelium rather than with the regeneration of more Barrett mucosa. The ablative therapies destroy metaplastic tissue but do not provide a pathology specimen by which to judge the depth of neoplastic invasion and the completeness of the ablation. In contrast, EMR and endoscopic submucosal dissection provide large tissue specimens that can be examined by the pathologist to determine the character and extent of the mucosal abnormality and, for neoplastic lesions, the depth of involvement and the adequacy of resection. Although early studies focused on using either ablation or EMR for the treatment of neoplasia in Barrett esophagus, now these two techniques often are used in combination. The term EET is used to describe the use of any one or combination of endoscopic modalities with the goal of completely eradicating Barrett metaplasia. EET can eliminate neoplasms that are confined to the esophageal mucosa but cannot cure cancers that have metastasized to lymph nodes. For patients with esophageal adenocarcinomas that involve the submucosa, the frequency of lymph node metastases exceeds 10% and, therefore, EET generally is not advised. 109,110 However, even mucosal neoplasms have the potential to metastasize to lymph nodes. A systematic review on the frequency of lymph node metastases in Chapter 47 Barrett esophagus 697 47 patients with mucosal neoplasms in Barrett esophagus identified 70 relevant reports that included 1,874 patients who had had esophagectomy performed for high-grade dysplasia or intramucosal carcinoma in Barrett esophagus. 111 lymph node metastases were found in only 26 patients, 1.39%. 95% CI, 86% to 1.92%. This low risk makes EET feasible. Endoscopic ablative therapies, see also Chapter 48. An ideal ablative technique would inflict an injury deep enough to destroy all abnormal epithelium but not so deep as to cause serious complications such as esophageal hemorrhage, perforation, and stricture formation. No ablative therapies have achieved this ideal, and all have been associated with serious complications. Randomized, controlled trials on the treatment of dysplasia have been conducted for PDT and RFA. For PDT, patients are given a systemic dose of a light-activated chemical that is taken up by the esophageal cells. The esophagus is then irradiated using a low-power laser that activates the chemical, which transfers that acquired energy to molecular oxygen. This transfer results in the formation of singlet oxygen, a toxic molecule that destroys the abnormal cells and their vasculature. In a multi-center randomized trial of PDT using porphymer sodium for high-grade dysplasia in Barrett esophagus, 138 patients were treated with PDT plus omeprazole 20 mg twice daily and 70 received omeprazole 20 mg twice daily alone. 112,113 No dysplasia was found on repeat endoscopy with biopsy in 77% of the patients treated with PDT as compared with 39% of the patients who received omeprazole alone, p. 0.0001. During up to 5 years of follow-up, 15% of the PDT patients developed cancer, compared with 29% of those treated with omeprazole alone, p equals 0.027. There was no procedure-related mortality, but 69% of the patients who received PDT developed photosensitivity reactions and 36% developed esophageal strictures, which were often difficult to treat. Because of this high rate of complications and the difficulty of the procedure, PDT has largely been abandoned as a treatment for dysplasia in Barrett esophagus in favor of RFA. RFA uses a balloon-based array of closely spaced electrodes to deliver radiofrequency, microwave, energy to ablate the esophageal mucosa. This system was designed with the intent of inflicting a uniform, circumferential thermal injury whose depth is controlled by a generator, which can vary the power, density, and duration of the energy applied. There are also smaller, radiofrequency catheter ablation devices that are used to ablate short segments of Barrett metaplasia or residual foci of metaplasia that persist after treatment with the balloon-based system. In a multi-center, randomized, sham-controlled trial of RFA, the ablation of intestinal metaplasia AIM dysplasia trial, 127 patients with dysplasia in Barrett esophagus, 64 low-grade, 63 high-grade, were randomly assigned to receive either RFA or a sham endoscopic procedure. 114 Intention to treat analysis at 1 year revealed complete eradication of dysplasia in 90.5% of patients with low-grade dysplasia in the ablation group, compared with 22.7% of those in the control group, p0.001. Similarly, complete eradication was found in 81.0% of patients with high-grade dysplasia in the ablation group, compared with 19.0% of those in the control group, p0.001. Complete eradication of intestinal metaplasia, CEIM, was found in 77.4% of all patients in the ablation groups, compared with 2.3% of those in the control group, p0.001. In addition, patients in the ablation group had less progression in their degree of neoplasia, 3.6% versus 16.3%, p equals 0.03, and fewer cancers noted at 1 year, 1.2% versus 9.3%, p equals 0.045. Serious complications occurred in 7% of the 84 patients who received ablation, including 1 upper GI hemorrhage and 5 esophageal strictures, which responded readily to treatment. In the European Surveillance versus Radiofrequency Ablation (SURF) trial, in which 136 patients with low-grade dysplasia confirmed by expert pathologists were randomized to receive either RFA or endoscopic surveillance, RFA reduced the risk of progression to high-grade dysplasia or adenocarcinoma by 25.0%, 1.5% for ablation versus 26.5% for control, 95% CI, 14.1% to 35.9%, p0.001, and the risk of progression to adenocarcinoma by 7.4%, 1.5% for ablation vs. 8.8% for control, 95% CI, 0% to 14.7%, p equals 0.03. 115 RFA is now widely regarded as the procedure of choice for ablating Barrett esophagus with dysplasia, both high-grade and low-grade. 116,117 in endoscopic cryotherapy, a cryogen such as compressed carbon dioxide or liquid nitrous oxide is applied endoscopically to the Barrett esophagus, causing rapid tissue freezing and thawing that disrupts cell membranes, induces apoptosis, and causes thrombosis of local blood vessels. 118 Unlike RFA, cryotherapy causes no permanent change in protein structure and, thus, preserves extracellular collagen matrix architecture. In theory, this might limit stricture formation, but the clinical advantage of cryotherapy in this regard is not yet established. Cryotherapy also might have advantages over RFA for the treatment of bulky lesions. Observational studies suggest that cryotherapy has efficacies similar to RFA for the eradication of Barrett metaplasia and dysplasia. 119-121 However, few long-term data are available, and RFA remains the most commonly used ablation technique at this time. Endoscopic mucosal resection, see also Chapter 48 and Video 47.2. EMR can be performed using a suck and cut method, in which the endoscopist elevates the dysplastic area by injecting fluid into the submucosa, after which the elevated mucosa is suctioned into a cap that fits over the tip of the endoscope. 122 A polypectomy snare is then deployed around the suctioned area to remove it. EMR also can be performed by the band and snare method that uses a ligating device, similar to that used for endoscopic variceal ligation, which deploys elastic bands around the suctioned mucosal segment without the requirement for prior submucosal fluid injection. 123 The banded segment is removed using a polypectomy snare, see Chapter 48. Available reports on limited, non-circumferential, EMR describe few serious complications and virtually no procedure-related mortality. However, esophageal stricturing occurs frequently if EMR is used to remove the entire circumferential extent of Barrett epithelium in a single endoscopic session. 124 Although EMR initially was developed as a therapeutic procedure, clinicians eventually came to appreciate the value of EMR as a procedure for T-staging early neoplasms in Barrett esophagus. Because of the high risk for lymph node metastases when Barrett neoplasms involve the submucosa, accurate T-staging of tumors is crucial to determine whether endoscopic therapy is feasible. EUS had been considered the most accurate diagnostic modality for T-staging, but a number of studies have shown that EUS has very limited accuracy for T-staging early neoplasia in Barrett esophagus. 125 In contrast, reports have described an excellent correlation between preoperative T-staging of early Barrett neoplasms using EMR and postoperative T-staging by examination of esophagectomy specimens. 126 As a result, gastroenterology societies now advise that nodular lesions and other visible irregularities in Barrett esophagus should be removed by EMR for T-staging prior to performing endoscopic ablation. If the EMR specimen shows submucosal invasion, then further endoscopic therapy is not advised. The long-term data that are available on the efficacy of EMR as primary treatment for early cancer in Barrett esophagus are limited. 698 Part V Esophagus but impressive. L and colleagues performed EMR on 100 patients with early adenocarcinomas in Barrett esophagus, tumor diameter 20 mm, well-differentiated histology, no invasion of lymphatics or blood vessels, and no evidence of metastases, submucosal invasion, or lymph node involvement. 127 There were no serious complications, and the calculated 5-year survival rate was an extraordinary 98%. However, recurrent or metachronous cancers were found in 11% of the patients during a mean follow-up period of 37 months. The recurrent tumors were treated successfully with more endoscopic therapy, but this high recurrence rate shows that EMR often leaves behind cells with neoplastic potential. A study from the Mayo Clinic compared long-term survivals in patients with high-grade dysplasia who were treated either with esophagectomy or with a combination of EMR and PDT. 128 There was no statistically significant difference in survival for patients treated with either of the therapies, even though 6.2% of the patients treated with PDT and EMR were found to have a metachronous esophageal cancer during the follow-up period. Another report describes the long-term results of endoscopic therapies in 349 patients who had high-grade dysplasia or mucosal adenocarcinoma in Barrett esophagus. 129 Endoscopic treatments included EMR alone for 279 patients, PDT alone for 55, EMR and PDT combined for 13, and argon plasma coagulation alone for 2 patients. Serious complications of endoscopic therapy occurred in 5% of cases, important bleeding in 2 patients, esophageal stricture in 15 patients. During a mean follow-up of 64 months, a complete remission, defined as complete elimination of the neoplastic lesion and at least one follow-up endoscopy showing no neoplasia, was achieved in 97%. The calculated 5-year survival rate was 84%, and none of the deaths were from esophageal cancer. However, metachronous neoplasms were found during the follow-up period in 21%. The investigators noted that a major risk factor for these metachronous lesions was failure to eradicate the residual, non-neoplastic Barrett epithelium. Metachronous neoplasms occurred in 17% of 200 patients who had their Barrett epithelium ablated after the primary neoplasm was removed, but in 30% of the 137 patients whose Barrett epithelium was not ablated. Based largely on this experience, experts now recommend that EET for mucosal neoplasms in Barrett esophagus should include an attempt to eradicate all the Barrett mucosa, not just the apparent foci of neoplasia. Status of EET for dysplasia in Barrett esophagus. EET now is widely regarded as the procedure of choice for treating mucosal neoplasia in Barrett esophagus, including low-grade dysplasia, high-grade dysplasia, and intramucosal carcinoma. However, before proceeding with EET for a finding of mucosal neoplasia, the Barrett esophagus should be carefully inspected. Seattle biopsy protocol specimens should be obtained at 1 cm intervals throughout the Barrett metaplasia segment, and any visible mucosal irregularities should be removed by EMR, which provides crucial staging information. EMR is now considered so important that the most recent ACT guideline states specifically that endoscopists who plan to practice endoscopic ablative procedures should additionally offer EMR 77. The diagnosis of dysplasia of any grade in endoscopic pinch biopsy or EMR specimens should be confirmed by a pathologist who has specialized expertise in gastrointestinal pathology. If the diagnosis of mucosal neoplasia is confirmed, all remaining Barrett metaplasia should be ablated, usually with RFA, to minimize the development of metachronous neoplasia. EET generally is not recommended when EMR reveals submucosal invasion, because of the high frequency of lymph node metastases in this situation. However, limited experience in expert centers using EET for tumors that had favorable histologic features and that penetrated only to the most superficial layer of the submucosa has yielded excellent long-term survival results. 130 Presently, EET for submucosal neoplasms in Barrett esophagus is highly controversial and should be considered an option only in expert centers. EET has far fewer complications than the once traditional dysplasia treatment of esophagectomy, but EET is far from risk-free. A recent systematic review and meta-analysis of 37 articles comprising 9,200 patients who had RFA with or without prior EMR found an 8.8%, 95% CI 6.5% to 11.9%, pooled rate of serious adverse events including esophageal strictures, 5.6%, 95% CI 4.2% to 7.4%, bleeding, 1%, 95% CI, 0.8% to 1.3%, and perforation, 0.6%, 95% CI, 0.4% to 0.9%. 131 Furthermore, the risk for adverse events was significantly higher when RFA was combined EMR than when RFA was used alone. Relative risk 4.4, p equals 0.015. Although esophagectomy has far more adverse effects than EET, there is still a role for esophagectomy in selected patients with mucosal neoplasia in Barrett esophagus. Esophagectomy may be needed in the minority of patients for whom EET fails to eradicate the neoplastic mucosa, especially those multiple foci of dysplasia scattered throughout long-segment Barrett esophagus. Esophagectomy also can be considered for patients who are unwilling or unable to adhere to the multiple endoscopic treatment sessions and surveillance procedures required to ensure treatment efficacy. See later. Early reports suggested that a condition called subsquamous intestinal metaplasia, SSIM, also called buried glands, was a complication of EET, but this does not appear to be true. 132 SSIM is the condition in which metaplastic glands, presumably with malignant potential, are present underneath esophageal squamous epithelium in the lamina propria, where they are invisible to endoscopists. SSIM was thought to be a consequence of incomplete endoscopic ablation procedures that eradicated the superficial layer of Barrett metaplasia but left behind a deeper glandular layer that was buried by neosquamous epithelium covering the ablation wound. However, recent reports suggest that the large majority of patients with Barrett esophagus who have never been treated with ablation have SSIM underlying esophageal squamous epithelium near its junction with Barrett metaplasia. 132,133 The pathogenesis and clinical importance of SSIM remains unclear. When considering EET, both patients and physicians should appreciate the importance of follow-up because recurrences of both metaplasia and neoplasia are frequent. In a retrospective cohort study of 218 patients who were treated with RFA for dysplasia in Barrett esophagus and who achieved CE-IM, 24%, experienced recurrence of metaplasia or neoplasia over 540.6 person-years, an overall recurrence incidence rate of 9.6%/year. 13430, 58%, of those achieved a second CE-IM, and 1.8% of total, 7.7% of recurrences, progressed to invasive adenocarcinoma, a cancer incidence rate 0.65%/year. In a systematic review and meta-analysis of 39 studies on EET, the pooled incidence of any recurrence was 7.5, 95% CI 6.1 to 9.0/100 patient years. 135 The pooled incidence of metaplasia recurrence rate was 4.8, 95% CI 3.8 to 5.9/100 patient years, whereas the dysplasia recurrence rate was 2.0, 95% CI 1.5 to 2.5/100 patient years. These worrisome recurrence rates suggest that all patients treated with EET should have surveillance endoscopy even after achieving CE-IM. Recurrences of Barrett metaplasia and dysplasia are most frequent in the first year after achieving CE-IM by EET. 136 Risk factors for recurrence include baseline dysplasia, long segment Barrett esophagus, and treatment at low-volume centers. 137 After achieving CE-IM for patients with high-grade dysplasia or intramucosal carcinoma in Barrett esophagus, current, opinion-based guidelines call for endoscopic surveillance every 3 months for the first year, every 6 months in the second year, and annually thereafter. 77 For patients with CE-IM after EET for low-grade dysplasia, opinion-based guidelines call for endoscopic. Chapter 47 Barrett esophagus 699 47 Surveillance every 6 months for the first year and annually thereafter. 77 A recent study designed to establish evidence-based surveillance intervals after RFA of Barrett esophagus suggests that a much attenuated schedule of endoscopic surveillance based on patient risk factors would provide similar cancer protection, but the proposed evidence-based surveillance program has not yet been endorsed by gastroenterology societies. 138 After EET, recurrences appear to involve the new squamocolumnar junction region predominantly. In a study of 198 patients who had 2 or more endoscopies performed after RFA had achieved CE-IM, investigators performed 4 quadrant biopsies at 1 cm intervals throughout the ablated area that was now lined by neosquamous epithelium, and biopsies were taken at the new squamocolumnar junction. 139 During a mean follow-up of 3 years, 32 patients, 16%, had a metaplasia or neoplasia recurrence. 29 of the 32 recurrences were at the squamocolumnar junction or 1 cm above it, and all of 3 recurrences in the more proximal esophagus were visible endoscopically. Based on these findings, the authors recommended a biopsy protocol involving 8 evenly spaced biopsies around the Z-line, 4 quadrant biopsies at 1 and 2 cm above Z-line, and more proximal biopsies only for visible abnormalities. EET for non-dysplastic Barrett metaplasia. Some authorities have proposed that EET should be offered to all patients with Barrett esophagus, not just those with dysplasia and early cancer. 140 These authorities argue that Barrett metaplasia can be neoplastic even if it does not manifest histologic features of dysplasia, that the efficacy of endoscopic surveillance as a cancer prevention strategy is questionable, and that the safety and efficacy of RFA already have been established in high-quality studies on the treatment of dysplasia. Elsirag and Graham even have argued that the practice of routinely performing polypectomy for colorectal polyps found during colonoscopy is intellectually identical to ablating non-dysplastic Barrett esophagus. 141 Despite these interesting arguments, several unresolved issues limit support for a policy of EET for patients with non-dysplastic Barrett esophagus. The frequent recurrence of metaplasia discussed earlier suggests that EET will not eliminate the need for endoscopic surveillance. Other considerations that should temper enthusiasm for using EET to treat non-dysplastic Barrett esophagus include the fact that EET generally requires several endoscopic procedures to achieve complete eradication of Barrett metaplasia, entailing substantial expense and patient inconvenience. EET has a considerable rate of complications, and its efficacy in reducing the already low rate of cancer development in non-dysplastic Barrett esophagus has not established. Presently, EET is not recommended for the general population of patients with Barrett esophagus in the absence of dysplasia. 77 Recommendations. No management strategy for patients with Barrett esophagus has been verified by definitive studies demonstrating that it prolongs life or prevents deaths from esophageal cancer. We support the general management strategies proposed by the American Gastroenterological Association (AC) and ASGE with minor modifications as follows. Patients with Barrett esophagus should be treated with PPIs in whatever dose is necessary to control GERD symptoms and eliminate endoscopic signs of reflux esophagitis. Asymptomatic patients without reflux esophagitis can be treated with once-daily PPI therapy for chemoprevention. Anti-reflux surgery can be considered as an alternative to chronic PPI therapy for patients concerned about putative adverse PPI effects, but anti-reflux surgery is not clearly superior to PPIs for cancer prophylaxis. For patients with non-dysplastic Barrett esophagus, the risks and benefits of endoscopic surveillance should be presented in detailed discussion. Those who opt for surveillance should have it performed at intervals of every 3 to 5 years. Surveillance should be performed using high-resolution white light endoscopy. Endoscopists trained in advanced imaging techniques may find them useful, but advanced imaging is not required for routine surveillance. The endoscopist should inspect the Barrett metaplasia carefully. For areas that appear irregular or suspicious for neoplasia, the endoscopists should take targeted biopsies or, preferably, the suspicious area should be removed by EMR. In addition to these targeted specimens, the endoscopist should take 4-quadrant biopsy specimens every 2 cm throughout the length of the Barrett metaplasia. In patients already known to have dysplasia, 4-quadrant biopsy specimens should instead be taken every 1 cm throughout the length of the Barrett metaplasia. If biopsies are read as indefinite for dysplasia, PPI therapy should be optimized and endoscopy repeated in approximately 8 weeks, with biopsy specimens taken at 1 cm intervals. If the diagnosis of indefinite for dysplasia persists, management options include surveillance endoscopy every 12 months or referral to a center with special expertise in managing Barrett esophagus. When dysplasia of any grade is first noted, if there is any question regarding the adequacy of the initial examination, another endoscopy should be performed as soon as feasible with extensive biopsy sampling to look for invasive cancer. EMR should be performed in areas of mucosal irregularity. The histology slides should be interpreted by an expert pathologist, preferably more than one expert. EET is recommended for patients with verified mucosal neoplasia, low-grade dysplasia, high-grade dysplasia, intramucosal carcinoma, after extensive biopsy sampling and EMR of mucosal irregularities. After achieving CEIM for patients with high-grade dysplasia or intramucosal carcinoma in Barrett esophagus, endoscopic surveillance is performed every 3 months for the first year, every 6 months in the second year, and annually thereafter. After achieving CEIM for patients with low-grade dysplasia, endoscopic surveillance is performed every 6 months for the first year, and annually thereafter. Full references for this chapter can be found on www.expertconsult.com. Video 47.1 APC Therapy of Dysplastic Barrett Esophagus. Video 47.2 EMR of high-grade dysplasia in Barrett esophagus. 699.E1 699.E2 References 1. S. Peckler S.J., Fitzgerald R.C., Prasad G.A., ETAL History, Molecular Mechanisms, and Endoscopic Treatment of Barrett's Esophagus. Gastroenterology 2010, 138:85469. 2. Barrett NR Chronic Peptic Ulcer of the Esophagus and Esophagitis. BRJSURG 1950, 38:17582. 3. T. Rift AP. The Epidemic of Esophageal Carcinoma, Where Are We Now? Cancer Epidemial 2016, 41:8895. 4. C. Handrosoma P. Weichtung S., Demeester S., ETAL columnar-lined esophagus without intestinal metaplasia has no proven risk of adenocarcinoma. AMJ-SURG Pathol 2012, 36:17. 5 R. Idel RH, AJ-RD definition of Barrett's esophagus, time for a rethink. Is intestinal metaplasia dead? AMJ Gastrointestinal 2009, 104:258894. 6S Harma P. Morales TG, Sampliner re short segment Barrett's esophagus. The need for standardization of the definition and of endoscopic criteria. AMJ Gastrointestinal 1998, 93:1033-6. 7S Peckler SJ, Zirujan JM, Anton Iolide, ETAL prevalence of metaplasia at the gastroesophageal junction. Lancet 1994, 344:1533-6. 8S Harma P, Dent J, Armstrong D, ETL. The development and validation of an endoscopic grading system for Barrett's esophagus, the PROG C&M criteria. Gastroenterology 2006, 131:1392-9. 9C Amaran AJ. Epidemiology of columnar-lined esophagus and adenocarcinoma. Gastroenterol Clin NM 1997, 26:487-94. 10 H. Asal E. Esophageal metaplasia, definition and prevalence in childhood. Gastrointestinal Endosc 2006, 64:676-7. 11 W. Ang A., Matek NC, Halab JL, ETAL prevalence of complicated gastroesophageal reflux disease and Barrett's esophagus among racial groups in a multi-center consortium. Dig Dis Sci 2009, 54:964-71. 12 S. Hayata S., Singh S., and Shai Sai A., Elsirag HB. Prevalence of Barrett's esophagus in Asian countries, a systematic review and meta-analysis. Clin Gastroenterol Hepatil 2015, 13:1907. 13 COKMB, Shaheen New Jersey, Anderson LA, ETAL cigarette smoking increases risk of Barrett's esophagus, an analysis of the Barrett's and esophageal adenocarcinoma consortium. Gastroenterology 2012, 142:744-53. 14 RxDK, Cummings Au, Shaw M., ETAL screening for Barrett's esophagus in colonoscopy patients with and without heartburn. Gastroenterology 2003, 125:1677. 15 R. Onkinen J., Aero P., Sterscrub T., ETAL prevalence of Barrett's esophagus in the general population, an endoscopic study. Gastroenterology 2005, 129:1825-31. 16 S. Hayheen New Jersey, Crosby Ma, Bozimski M., Sandler Rs. Is there publication bias in the reporting of cancer risk in Barrett's esophagus? Gastroenterology 2000, 119:333-8. 17 D. E. Sai TK, Krishnan K., Samala N., ETL. The incidence of esophageal adenocarcinoma in non-dysplastic Barrett's esophagus, a meta-analysis. Gut 2012, 61:976. 18 W. Ani S., Falk G., Hall M., ETAL patients with non-dysplastic Barrett's esophagus have low risks for developing dysplasia or esophageal adenocarcinoma. Clin Gastroenterol Hepatil 2011, 9:227. 19 Behat S., Coleman H.G., Youssef F., ETAL risk of malignant progression in Barrett's esophagus patients, results from a large population-based study. J. Natal Cancer INST 2011, 103:1049-57. 20 HVID Jensen F., Peterson L., Drews A.M., ETAL incidence of adenocarcinoma among patients with Barrett's esophagus. N. English J. Med 2011, 365:1375-83. 21 S. Uza R.F., Speckler S.J. Concepts in the Prevention of Adenocarcinoma of the Distal Esophagus and Proximal Stomach. CA Cancer J. Clin 2005, 55:334-51. 22 W. Inberg H., Lindblad M., Lagergren J., ETAL Risk Factors and Chemoprevention in Barrett's Esophagus. An update. Scanned J. Gastroenterol 2012, 47:397-406. 23 P. Ol H., Vrobel K., Boyarsky C., ETAL Risk Factors in the Development of Esophageal Adenocarcinoma. AMJ Gastroenterol 2013, 108:207. 24 T. Hrift AP Determination of Risk for Barrett's Esophagus and Esophageal Adenocarcinoma. Kuropin Gastroenterol 2016, 32:319-24. 25 L. Lagergren J. Influence of Obesity on the Risk of Esophageal Disorders. Nat Rev Gastroenterol Hepatil 2011, 8:347. 26 I. Ijima K., Henry E., Moria A., ETAL Dietary nitrate generates potentially mutagenic concentrations of nitric oxide at the gastroesophageal junction. Gastroenterology 2002, 122:1248-57. 27 Hershowitz by Gastric acid and pepsin secretion in patients with Barrett's esophagus and appropriate controls. Dig Dis Sci 1996, 41:1384-91. 28 Fletcher J., Wers A., Henry E., ETAL Studies of acid exposure immediately above the gastroesophageal junction, evidence of short segment reflux. Gut 2004, 53:168-73. 29 Burke Z.D., Tosh D. Barrett's metaplasia as a paradigm for understanding the development of cancer. Kuropin Genet Dev 2012, 22:494-9. 30 Wang D.H. The esophageal squamous epithelial cell still a reasonable candidate for the Barrett's esophagus cell of origin? Cell mole Gastroenterol Hepatil 2017, 4:157-60. 31 Garman K.S. Origin of Barrett's epithelium, esophageal submucosal glands. Cell mole Gastroenterol Hepatil 2017, 4:153-6. 32 Quant M., Boggett G., Abrams J.A., ETAL Bile acid and inflammation activate gastric cardia stem cells in a mouse model of Barrett-like metaplasia. Cancer Cell 2012, 2136-51. 33 Wang X., Ouyang H., Yamamoto Y., ETAL residual embryonic cells as precursors of a Barrett's-like metaplasia. Cell 2011, 145:1023-35. 34 Zhang M., Li H., Zhang Y., ETAL transitional basal cells at the squamous columnar junction generate Barrett's esophagus. Nature 2017, 550:529-33. 35 Sarosi G., Brown G., Jaiswal K., ETAL bone marrow progenitor cells contribute to esophageal regeneration and metaplasia in a rat model of Barrett's esophagus. Dis Esophagus 2008, 21:43-50. 36 Souza R.F., Krishnan K., Speckler S.J. Acid, bile, and CDX, the ABCs of making Barrett's metaplasia. AMJ Physiol Gastrointestinal Liver Physiol 2008, 295 G211-8. 37 Wang D.H., Clemens New Jersey, Miyashita T., ETAL Aberrant epithelial mesenchymal hedgehog signaling characterizes Barrett's metaplasia. Gastroenterology 2010, 138:1810-22. 38 Wang D.H., Tewari A., Kim Mi, Clemens New Jersey, Regmi N.L., Hodges W.A., Berman D.M., Montgomery E.A., Watkins D.N., Zhang X., Zhang Q., G.C., Speckler S.J., Souza R.F. Hedgehog signaling regulates FOXA2 in esophageal embryogenesis and Barrett's metaplasia. J. Klin Invest 2014, 124:37-67-80. 39 Dixon J., Strugala V., Griffin S.M., ETAL esophageal mucin, an adherent mucus gel barrier is absent in the normal esophagus but present in columnar-lined Barrett's esophagus. AMJ Gastroenterol 2001, 96:257583. 40 Yavov B., Vanatali CM, Shaheen, New Jersey, ETAL Claudin 18, a dominant tight junction protein in Barrett's esophagus and likely contributor to its acid resistance. AMJ Physiol Gastrointestinal Liver Physiol 2007, 293 G 110613. 41 Hanahan D., Weinberg R.A. The Hallmarks of Cancer. Cell 2000, 100:5770. 42 Hanahan D., Weinberg R.A. Hallmarks of Cancer, The Next Generation. Cell 2011, 144:64674. 43 Souza R.F., Morales C.P., Speckler S.J. Review article, A Conceptual Approach to Understanding the Molecular Mechanisms of Cancer Development in Barrett's Esophagus. Aliment Pharmacolther 2001, 15:1087-100. 44 Fouadier, ANEIC Revisiting the Hallmarks of Cancer. AMJ Cancer Res 2017, 7:101636. 45 Fritcher E.G., Brankley S.M., Kip B.R., et.al. A Comparison of Conventional Cytology, DNA ploidy analysis, and fluorescence in situ hybridization for the detection of dysplasia and adenocarcinoma in patients with Barrett's esophagus. Hum Pathol 2008, 39, 1128-35. 46 Huang Q, UC, Zhang X, ETAL Comparison of DNA histograms by standard flow cytometry and image cytometry on sections in Barrett's adenocarcinoma. BMC Clin Pathol 2008, 8:5. 47 Rigel AM, Milano F, 10 Kate FJ, ETAL Assessment of chromosomal gains as compared to DNA content changes is more useful to detect dysplasia in Barrett's esophagus brush cytology specimens. Genes Chromosomes Cancer 2008, 47:396-404. 48 Picardo S.L., Mar S.G., O'Sullivan J.N., ETAL Barrett's to esophageal cancer sequence, a model of inflammatory-driven upper gastrointestinal cancer. Dig SURG 2012, 29:251-60. 49 Alluri S., Claver E., Ditz L.C., Jackson S.A., Bergman J.J., Shaheen, New Jersey. Validation of a biomarker panel in Barrett's esophagus to predict progression to esophageal adenocarcinoma. Dis Esophagus 2018 April 3. https://doi.org/10.1093/dot/doi026. EPUB ahead of print. 50 Stackler M.D., Taylor Wiener A., Peng S., ETAL Paired Exome Analysis of Barrett's Esophagus and Adenocarcinoma. Nat Genet 2015, 47:1047-55. 51 E.K. Wee, Levine D.M., D'Amato M., ETAL Germline Genetic Contributions to Risk for Esophageal Adenocarcinoma, Barrett's Esophagus, and Gastroesophageal Reflux. J. Natal Cancer INST 2013, 105, 1711-8. 52 Buas M.F., HEQ, Johnson L.G., ETAL Germline Variation in Inflammation-Related Pathways and Risk of Barrett's Esophagus and Esophageal Adenocarcinoma. Gut 2017, 66:1739-47. 53 Dai Jai, Dadu Tapsabajay, Buas M.F., ETAL. A newly identified susceptibility locus near FOXP1 modifies the association of gastroesophageal reflux with Barrett's esophagus. Cancer epidemial biomarkers previous 2015, 24:1739-47. 54 Speckler S.J., Sharma P., Souza R.F., ETAL American Gastroenterological Association Technical Review on the Management of Barrett's Esophagus. Gastroenterology 2011, 140 E1852. 55 Speckler S.J. Dysplasia in Barrett's Esophagus, Limitations of Current Management Strategies. AMJ Gastroenterol 2005, 100, 927-35. 56 Skolvink D.W., Van der Meulen K., Bergman JJGHM, Wussen BLAM. Detection of lesions in dysplastic Barrett's esophagus by community and expert endoscopists. Endoscopy 2017, 49:11320. 57 Levine DS, Blount PL, Rudolf Reed BJ. Safety of a systematic endoscopic biopsy protocol in patients with Barrett's esophagus. AMJ Gastroenterol 2000, 95:1152-7. 58 Cotton CC, Ditz LC, Wolf WA, Peary AF, Dellen ES, Bergman JJ, Shaheen New Jersey. Spatial predisposition of dysplasia in Barrett's esophagus segments, a pooled analysis of the SURF and AIM dysplasia trials. AMJ Gastroenterol 2015, 110:1412-9. 59 Visrodia K., Singh S., Krishnamurthy R., Alquist D., Wang KK, IRPG, Catskita magnitude of missed esophageal adenocarcinoma after Barrett's esophagus diagnosis, a systematic review and meta-analysis. Gastroenterology 2016, 150:599607. 60 Collard JM. High-grade dysplasia in Barrett's esophagus. The case for esophagectomy. Chest SURG Clin North M 2002, 12:7792. 61 Konda VJ, Ross As, Ferguson MK, ETL. Is the risk of concomitant invasive esophageal cancer in high-grade dysplasia in Barrett's esophagus overestimated? Clin Gastroenterol Hepital 2008, 6, 159-64. 62 Curvers WL, Bergman JJ. Multimodality imaging in Barrett's esophagus, looking longer, seeing better, and recognizing more. Gastroenterology 2008, 135:2979. 63 Sharma P., Brill J., Canto M., DeMarco D., Fenerty B., Gupta N., Lane L., Lieberman D., Lightdale C., Montgomery E., Aj R., Talker J., Kochman M. White Paper AGA, Advanced Imaging in Barrett's Esophagus. Clin Gastroenterol Hepital 2015, 13, 220918. 64 Kambaje AK, Khan A., Wolfson HC, Trindade AJ, Ganguly EK, Otaki F., Chan D., Zako L., Visrodia K., Lutsk L., Wang KK, Leggett CL. Volumetric laser endomicroscopy interpretation and feature analysis in dysplastic Barrett's esophagus. J. Gastroenterol Hepital 2018 April 6. EPUB ahead of print. 65 Sharma P., Falk GW, Weston AP, ETAL dysplasia and cancer in a large multi-center cohort of patients with Barrett's esophagus. Clin Gastroenterol Hepital 2006, 4:56672. 66 Curvers WL, 10 Kate FJ, Krishnadath KK, ETAL low-grade dysplasia in Barrett's esophagus, overdiagnosed and underestimated. AMJ Gastroenterol 2010, 105:152330. 67 Wani S., Falk GW, Post J., ETAL risk factors for progression of low-grade dysplasia in patients with Barrett's esophagus. Gastroenterology 2011, 141:117986. 68 Zhang Hai, Hormai Carver K., Zhang X., ETL. In benign Barrett's epithelial cells, acid exposure generates reactive oxygen species that cause DNA double-strand breaks. Cancer Res 2009, 69:9083-9. 69 Waitalasker R., Fitzgerald R.C., Triadaphilopoulos G. Differentiation and proliferation in Barrett's esophagus and the effects of acid suppression. Gastroenterology 1999, 117:32735. 70 Elsirag H.B., Agir TV, Davis S., ETAL proton pump inhibitors are associated with reduced incidence of dysplasia in Barrett's esophagus. AMJ Gastroenterol 2004, 99:187783. 71 Hillman L.C., Chiragakis L., Shadbolt B., ETAL proton pump inhibitor therapy and the development of dysplasia in patients with Barrett's esophagus. Med J. Ost 2004, 180:38791. References 699.E372. Kastlein F., Sponder M.C., Steyerberg U., Prober Study Group, ETL. Proton pump inhibitors reduce the risk of neoplastic progression in patients with Barrett's esophagus. Clin Gastroenterol Hepital 2013, 11:382-8. 73 Singh S., Garg S.K., Singh P.P., ETAL acid suppressive medications and risk of esophageal adenocarcinoma in patients with Barrett's esophagus, a systematic review and meta-analysis. Gut 2014, 63:1229. 74 Hu Q, Sun T.T., Hong J., Feng Jai, Xiong H., Meltzer S.J. Proton pump inhibitors do not reduce the risk of esophageal adenocarcinoma in patients with Barrett's esophagus, a systematic review and meta-analysis. +1 2017, 12, 1E01696991. 75 Brusselaers N., Engstrand L., Lagergren J. Maintenance proton pump inhibition therapy and risk of esophageal cancer. Cancer Epidemial 2018, 53:172-7. 76 Tan MC, Elsirag HB, UX, Thrift AP acid suppression medications reduce risk of esophageal adenocarcinoma in Barrett's esophagus, a nested case control study in U.S. male veterans. Aliment Pharmacolder 2018 June 29. EPUB ahead of print. 77 Shaheen New Jersey, Falk GW, IRPG, Gerson LB, American College of Gastroenterology. ACT Clinical Guideline, Diagnosis and Management of Barrett's Esophagus. AMJ Gastroenterol 2016, 111:3050. 78 Gerson LB, Bopper AV, Dola N., ETAL esophageal and gastric pH profiles in patients with gastroesophageal reflux disease and Barrett's esophagus treated with proton pump inhibitors. Aliment Pharmacolder 2004, 20:63743. 79 Speckler S.J., Sharma P., Traxler B., ETAL gastric and esophageal pH in patients with Barrett's esophagus treated with 3 esomeprazole dosages, a randomized, double-blind, crossover trial. AMJ Gastroenterol 2006, 101:196471. 80 Speckler S.J., Lee E., Anand D., ETAL long-term outcome of medical and surgical treatments for gastroesophageal reflux disease. Follow-up of a randomized controlled trial. JAM Med Association 2001, 285:2331-8. 81 Ye W., Chow W.H., Lagergren J., ETAL a risk of adenocarcinoma of the esophagus and gastric cardia in patients with gastroesophageal reflux diseases and after anti-reflux surgery. Gastroenterology 2001, 121:1286-93. 82 Tran T., Speckler S.J., Elsirag H.B. Funduplication and the risk of cancer in gastroesophageal reflux disease, a Veterans Affairs cohort study. AMJ Gastroenterol 2005, 100:1002-8. 83 Chong E.Y., Morris C.D., Seltman A.K., ETL. The effect of anti-reflux surgery on esophageal carcinogenesis in patients with Barrett esophagus, a systematic review. An SURG 2007, 246:1121. 84 Maratida J., Konings P., Lagergren J., Brusselaers N. Anti-reflux surgery and risk of esophageal adenocarcinoma, a systematic review and meta-analysis. An SURG 2016, 263:2517. 85 Molina Ma, Sitja Arno M., Lemoyne M.G., ETAL increased cyclooxygenase 2 expression in human pancreatic carcinomas and cell lines, growth inhibition by nonsteroidal anti-inflammatory drugs. Cancer Res 1999, 59:435662. 86 Piazza Ga, Ram Al, Krutz M, ETAL Antineoplastic drugs Solindac sulfide and sulfone inhibit cell growth by inducing apoptosis. Cancer Res 1995, 5531-106. 87 Bres Allier Rs. Chemoprevention of Barrett's esophagus and esophageal adenocarcinoma. Dig Dis Sci 2018-12. https://doi.org/10.1007/S10620018-5149-6. EPUB ahead of print. 88 Souza RF, Shoemake K, Beer DG, ETAL selective inhibition of cyclooxygenase 2 suppresses growth and induces apoptosis in human esophageal adenocarcinoma cells. Cancer Res 2000, 60:576772. 89 Butta NS, Wang KK, Anderson Ma, ETAL. The effect of selective cyclooxygenase 2 inhibition in Barrett's esophagus epithelium, an in vitro study. J. Natal Cancer INST 2002, 94:4229. 90 Agarwal S, Taneja N, Lin L, ETAL indomethacin-induced apoptosis in esophageal adenocarcinoma cells involves upregulation of BAX and translocation of mitochondrial cytochrome C independent of COX-2 expression in process citation. Neoplasia 2000, 2:34656. 91 Von Roden BH, Stein HJ, Puringer F, ETAL co-expression of cyclooxygenases, COX-1, COX-2, and vascular endothelial growth factors, VEGF-A, VEGF-C, in esophageal adenocarcinoma. Cancer Res 2005, 65:503844. 4792. Butta NS, Wang KK, Lian Tavi Shou, ETAL chemoprevention of esophageal adenocarcinoma by COX-2 inhibitors in an animal model of Barrett's esophagus. Gastroenterology 2002, 122:110112. 699.E4 References 93. Oyama K, Fujimura T, Ninomiya I, ETL. A COX-2 inhibitor prevents the esophageal inflammation metaplasia adenocarcinoma sequence in rats. Carcinogenesis 2005, 26:56570. 94 KIMSW, Zhang TJ, Jung KH, ETAL Solindac prevents esophageal adenocarcinomas induced by gastroduodenal reflux in rats. Yonsei Med J 2007, 48:1027. 95 F Alk GW, Butta NS, Foster NR, Cancer Prevention Network, ETL. A combination of esomeprazole and aspirin reduces tissue concentrations of prostaglandin E, 2, in patients with Barrett's esophagus. Gastroenterology 2012, 143:91726. 96 G Alipo PC, Oman KM, Paulson TG, ETAL NSAID use and somatic exomic mutations in Barrett's esophagus. Genome Med 2018, 10:17. 97 C Orly D, Kurlikowsk K, Verma R, ETAL Protective Association of Aspirin/NSAIDs and Esophageal Cancer, a Systematic Review and Meta-Analysis. Gastroenterology 2003, 124:4756. 98 V ANTL, Dong LM, Blount PL, ETAL nonsteroidal anti-inflammatory drugs and risk of neoplastic progression in Barrett's esophagus, a prospective study. Lancet Oncle 2005, 6:94552. 99 K Astleen F, Sponder MC, Bierman K, Prober Study Group, ETL. Nonsteroidal anti-inflammatory drugs and statins have chemopreventative effects in patients with Barrett's esophagus. Gastroenterology 2011, 141:2008. 100 ABNet CC, Friedman ND, Kamangar F, ETAL nonsteroidal anti-inflammatory drugs and risk of gastric and esophageal adenocarcinomas, results from a cohort study and a meta-analysis. BRJ Cancer 2009, 100:551-7. 101 American Gastroenterological Association, Speckler S.J., Sharma P., et al. American Gastroenterological Association Medical Position Statement on the Management of Barrett's Esophagus. Gastroenterology 2011, 140:1084-91. 102 Speckler S.J. Screening and Surveillance for Barrett's Esophagus, an Unresolved Dilemma. Nat Clin Pract Gastroenterol Hepital 2007, 4:471. 103 C. Odapalli D.C., Shandar A.K., Singh S., Wani S., Shaheen New Jersey, Inatami J.M., Chalk A., IRPG. The Effect of Endoscopic Surveillance in Patients with Barrett's Esophagus, a Systematic Review and Meta-Analysis. Gastroenterology 2018, 154:2068-86. 104 ASGE Standards of Practice Committee, Evans J.A., Early D.S., et al. The Role of Endoscopy in Barrett's Esophagus and Other Premalignant Conditions of the Esophagus. Gastrointestinal 2012, 76:1087-94. 105 S. Hayheen, New Jersey, Weinberg D.S., Denberg T.D., et al. For the Clinical Guidelines Committee of the American College of Physicians. Upper Endoscopy for Gastroesophageal Reflux Disease, Best Practice Advice from the Clinical Guidelines Committee of the American College of Physicians. An Intern Med 2012, 157:808-16. 106 F. Fitzgerald R.C., De Pietro M., Raghunath K., British Society of Gastroenterology, ETAL British Society of Gastroenterology Guidelines on the Diagnosis and Management of Barrett's Esophagus. Gut 2014, 63:742. 107 W. Yusin B., Bischops R., Korani, Dinis Ribeiro M., Dumonso J. M., Esteban J. M., Hassan C., Pecco, Ripisai A., Bergman J., De Pietro M. Endoscopic Management of Barrett's Esophagus, European Society of Gastrointestinal Endoscopy, ESGE, Position Statement. Endoscopy 2017, 49:1918. 108 Standards of Practice Committee, Wani S., Kumzia B., Sultan S., Agrawal D., Chandrasekhara V., Harnk B., Kothari S., MacArthur M., Kakut A., Wang A., Yang J., DeWitt J. Endoscopic Eradication Therapy for Patients with Barrett's Esophagus-Associated Dysplasia and Intramucosal Cancer. Gastrointestinal 2018, 87:90731. 109 L. Ears J. M., Demeester S. R., Urslik A., et al. The Prevalence of Lymph Node Metastases in Patients with T1 Esophageal Adenocarcinoma, a Retrospective Review of Esophagectomy Specimens. An SURG 2011, 253:2718. 110 B. Idradine R. J., Prasad G. A., Lewis J. T., ETAL Depth of submucosal invasion does not predict lymph node metastasis and survival of patients with esophageal carcinoma. Clin Gastroenterol Hepital 2010, 8:248-53. 111 D. Unbar KB, Speckler S.J. The risk of lymph node metastases in patients with high-grade dysplasia or intramucosal carcinoma in Barrett's esophagus, a systematic review. AMJ Gastroenterol 2012, 107:850-62. 112 Overholt B.F., Lightdale C.J., Wang K.K., ETAL International Photodynamic Group for High-Grade Dysplasia in Barrett's Esophagus. Photodynamic Therapy with Porphymer Sodium for Ablation of High-Grade Dysplasia in Barrett's Esophagus, International, partially blinded, randomized Phase 3 trial. Gastrointestinal 2005, 62, 488-98. 113 Overholt B.F., Wang K.K., Burdick J.S., et al. On behalf of the International Photodynamic Group for High-Grade Dysplasia in Barrett's Esophagus. 5-year efficacy and safety of photodynamic therapy with Fordtran in Barrett's high-grade dysplasia. Gastrointestinal 2007, 66:468. 114 Shaheen, New Jersey, Sharma P., Overholt B.F., ETAL radiofrequency ablation in Barrett's esophagus with dysplasia. N. English J. Med 2009, 360:227788. 115 Foa Kn, Van Vilsteren F.G., Wussen B.L., ETAL radiofrequency ablation vs endoscopic surveillance for patients with Barrett esophagus and low-grade dysplasia, a randomized clinical trial. JAM Med Association 2014, 311:120917. 116 Kumzia B.J., Wani S., Gendi S., Harnk B., Bergman J.J., Wolfson H. Disease progression in Barrett's low-grade dysplasia with radiofrequency ablation compared with surveillance, systematic review and meta-analysis. AMJ Gastrointestinal 2017, 112:84965. 117 Wani S., Rubenstein J.H., VFM, Bergman J. Diagnosis and Management of Low-Grade Dysplasia in Barrett's Esophagus, Expert Review from the Clinical Practice Updates Committee of the American Gastroenterological Association. Gastroenterology 2016, 151:82235. 118 Overwater A., Wussen BLAM. Cryoablation in the Management of Barrett's Esophagus. Kuropin Gastroenterol 2017, 33:26019. 119 Shaheen, New Jersey, Greenwald BD, Piri AF, ETAL Safety and Efficacy of Endoscopic Spray Cryotherapy for Barrett's Esophagus with High-Grade Dysplasia. Gastrointestinal 2010, 71:680. 120 Gosain S., Mercer K., Twaddle WS, ETAL Liquid Nitrogen Spray Cryotherapy in Barrett's Esophagus with High-Grade Dysplasia, Long-Term Results. Gastrointestinal 2013, 78:260. 121 Kanto MI, Shin EJ, Kashav Ma, ETAL Safety and Efficacy of Carbon Dioxide Cryotherapy for Treatment of Neoplastic Barrett's Esophagus. Endoscopy 2015, 47:582. 122 Ahmadi A., Draganov P. Endoscopic mucosal resection in the upper gastrointestinal tract. World J. Gastroenterol 2008, 14. 1984-9. 123 Peters F.P., Karam Ma, Curvers WL, ETAL Multiband Mucosectomy for Endoscopic Resection of Barrett's Esophagus, Feasibility Study with Matched Historical Controls. Ure J. Gastroenterol Hepatal 2007, 19:311-5. 124 Konda VJA, Speckler S.J. Endoscopic Eradication Therapy and the Test of Time. Gastrointestinal 2018, 87:857. 125 Waxman I, Ra UGS, Critchlow J. ETAL high-frequency probe ultrasonography has limited accuracy for detecting invasive adenocarcinoma in patients with Barrett's esophagus and high-grade dysplasia or intramucosal carcinoma, a case series. AMJ Gastroenterol 2006, 101:1773-9. 126 Namasive MV, Wang KK, Prasad GA endoscopic mucosal resection in the management of esophageal neoplasia, current status and future directions. Clin Gastroenterol Hepatal 2010, 8:743-54. 127 LC, May A, PECO, ETAL curative endoscopic resection of early esophageal adenocarcinomas, Barrett's cancer. Gastrointestinal 2007, 65:310. 128 Prasad GA, Wang KK, Butta NS, ETAL long-term survival following endoscopic and surgical treatment of high-grade dysplasia in Barrett's esophagus. Gastroenterology 2007, 132:1226-33. 129 PECO, Barron's A., May A., ETAL long-term results and risk factor analysis for recurrence after curative endoscopic therapy in 349 patients with high-grade intraepithelial neoplasia and mucosal adenocarcinoma in Barrett's esophagus. Gut 2008, 57:1206. 130 Manor H., Peck O., Heldman Y., et al. The frequency of lymph node metastasis in early-stage adenocarcinoma of the esophagus with incipient submucosal invasion, PT1B-SM1, depending on histological risk patterns. SURG Endosc 2015, 29:188896. 131 Kumzia B.J., Wani S., Desai M., Kumzia A., Bain P., Sharma P., Wolfson H. Adverse events after radiofrequency ablation in patients with Barrett's esophagus, a systematic review and meta-analysis. Clin Gastroenterol Hepatil 2016, 14:108695. 132 Gray N.A., Aj R.D., Speckler S.J. Buried metaplasia after endoscopic ablation of Barrett's esophagus, a systematic review. AMJ Gastroenterol 2011, 106:1899908. 133 A. Enders M., Lux Y., L. Masri Ma, ETAL subsquamous extension of intestinal metaplasia is detected in 98% of cases of neoplastic Barrett's esophagus. Clin Gastroenterol Hepatil 2014, 12:40510. 134 G. Uthakanda A., Cotton C.C., Madanik R.D., ETAL clinical outcomes following recurrence of intestinal metaplasia after successful treatment of Barrett's esophagus with radiofrequency ablation. AMJ Gastroenterol 2017, 112:8794. 135 Fuji Lau LL, Sinner B., Shaheen N., ETAL recurrence of intestinal metaplasia and early neoplasia after endoscopic eradication therapy for Barrett's esophagus, a systematic review and meta-analysis. Endoscint Open 2017, 5E43049. 136 Sawas T., IRPG, Alsawas M., ETAL higher rate of Barrett's detection in the first year after successful endoscopic therapy, meta-analysis. AMJ Gastroenterol 2018, 14. EPUB ahead of print. 137 T in MC, Kanthasami Ka, Ya AG, ETAL factors associated with recurrence of Barrett's esophagus after radiofrequency ablation. References 699.E5 Clin Gastroenterol Hepatil 2018, 11. Pi S 15423565, 18, 30595-0. https://doi.org/10.1016/j.cgh.2018.05.042. 138 Cotton CC, Hadri R., Thrift AP, Lovat L., Shaheen New Jersey. Development of evidence-based surveillance intervals after radiofrequency ablation of Barrett's esophagus. Gastroenterology 2018, 13. EPUB ahead of print. 139 Cotton CC, Wolf W.A., Pasri Shah S., Lee N., ETAL recurrent intestinal metaplasia after radiofrequency ablation for Barrett's esophagus, endoscopic findings and anatomic location. Gastrointest Endosc 2015, 81:1362-9. 140 Fleischer D., Aj R., Overholt B.F., ETL. The case for endoscopic treatment of non-dysplastic and low-grade dysplastic Barrett's esophagus. Dig Dis Sci 2010, 55:1918-31. 141 Elsirag HB, Gram DY routine polypectomy for colorectal polyps and ablation for Barrett's esophagus are intellectually the same. Gastroenterology 2011, 140:3868. 47.